I'm talking about a diffusilated antibody to CCR4 called mogamulizumab. It's been tested in a phase 1/2 trial and shown there is no maximum tolerated dose. So patients were dosed at 1 milligram per kg, and there was a good response rate of 37% overall, and higher in Sézary's, lower in MF patients, which was enough to justify a randomized phase 3 trial that's still going on. It seems that the Sézary patients respond very well to it. It gets rid of their circulating tumor cells in the blood with only 1 or 2 infusions. It's capable of giving long-term remissions that are durable and complete. Because it takes out T regulatory cells, it has a generalized potential activity in removing T regulatory cells that would suppress reactions to any kind of cancer. It's also been approved for Japanese HTLV1 induced T cell lymphoma. So it works there, and it has potential for other kinds of cancer as well through removal of T regulatory cells. CCR4 is a transmembrane receptor on the cell surface, and it binds to TARC, which is on endothelial cells, so it's really important in cell trafficking, getting out of the blood vessels and into the skin. The antibody works through ADCC, which is enhanced by removing the fusylated group on the antibody. So it's a new kind of antibody, a genetically engineered antibody this is the first test of that concept of removing the fusylated group there. I think that the melanoma story is compelling, that there's so many targeted therapies and immunotherapies, and I just hope some of the other cancers like CTCL will benefit from this explosion of checkpoint inhibitors and targeted trials. Well, there's several studies in progress. There's a cure antibody that looks active. There's some new RNA inhibitors of microRNA that are being tested. So this is really an exciting time for CTCL research, but we still don't have the magic bullet that cures people. So we have a lot of work still left to do.